It's really a pleasure to welcome Dr. Sondak. I have many reasons to thank Dr. Sondak, but he recruited me here from Utah not long ago. I'm going to brag a little bit. He truly is a giant in the field of melanoma. Has been working at Moffitt for going on now close to 20 years. I could say many things about his long list of accomplishments, but I think one of the things that I think is really important to understand about what Vern has given to our understanding of melanoma was as the lead of the Southwest Oncology Group during a chapter of time when our treatments as medical oncologists were not very good. So he lived through those really tough years and made terrific progress in basically laying the foundation that we have today to work on with our new drug. You're going to want to hear him talk, so I'm going to stop now and give him the mic. Dr. Sondak.
Thank you, Ken, for that, and thank you for joining us. And a big thank you to both Lois and Sam for setting this up, and always great to see such a big turnout here in our McKinley lobby here. One of the real great accomplishments of my time here at Moffitt was getting us moved over here, and we hope you guys who've had a chance to come visit us here have enjoyed it. We find it a much nicer, more peaceful place to take care of all of our patients here. So indeed, I am going to talk about some concepts that show how much melanoma treatment has changed and how that's influenced even what we do as surgeons. The principles of pathology that Dr. Chen just talked about have been the same principles that we've used for many years. The Clark's level and the Breslow's thickness were described in the 1960s, and wide excision, lymph node dissection for melanoma. These concepts were described in the 19th century, not the 20th century, but the 19th century, when the first idea that we have to take a wide excision around melanoma came along. And so really nothing about what we do surgically has changed, at least since the introduction of the Sentinel lymph node biopsy in the early 1990s. So technically almost every single thing we do is the same, but it seems like in the last couple of years everything we think about doing has changed. And I'm going to talk about this, what I call a paradigm shift, when I go everywhere around the country and even around the world. I was just in Italy giving a lecture on this very same topic, and surgeons and oncologists line up and they're just, well, what do we do now? There is such a high degree of, it's not even uncertainty, it's transition. It's a feeling like what I did yesterday doesn't seem right today, so what am I supposed to do now? And we'll talk about that and where that came from. So these guidelines were issued in 2012, and I just sort of show them as a framework and show you how much things have changed in 6 years. These were joint guidelines that were presented by the Society of Surgical Oncology, that's SSO, and ASCO, the American Society of Clinical Oncology. They've never actually issued any guidelines about any form of cancer surgery until 2012, when they issued these guidelines about melanoma surgery. And I didn't put in the margins. You were just talking with Dr. Chen about the margins, and to just make one thing perfectly clear. The surgeon measures that margin from the edge of what we can see to where we make the cut. So if we said we did a 1 centimeter margin, that's measured right there on that little teardrop or eyeball-shaped ellipse. We call that sometimes the melanoma eyeball because that's circle within an ellipse. 1 centimeter is the closest point to the cancer. The pathologist may look under the microscope and say, well, what you saw was 1 centimeter away. Under the microscope was crawling to within 3 millimeters of the edge. And she'll measure what's the closest cancer cell to the closest edge of the tumor. That doesn't change, and it doesn't make us go back and say, oh, we've got shortchanged 7 millimeters, we have to go back. We took a centimeter around that tumor, because if we'd only taken 3 millimeters around the tumor, we would have left 4 millimeters of tumor behind. We calculate how much to take based on these over 100 years of correlation of the size of the melanoma to the size it is under the microscope. Are we right every time? No. Probably 8 to 10% of the time, the melanoma didn't read the textbook, even if we wrote it. And it traveled farther than that centimeter or 2 centimeters that we took. Sometimes it's not even that the melanoma traveled, it's that the sun damage was so pervasive. Sun doesn't shine on the same spot only, it shines everywhere. Some people where the melanoma is in an area of such intensive sun damage, we go a centimeter and there's still melanoma cells developing or continuing from the same process. So that's that communication with the pathologist. Dr. Chen mentioned it, I'll echo it, is so important, and actually is one of the absolute hallmarks of what we do here at Moffitt. The pathologists are constantly communicating with us, constantly talking, constantly asking us questions. Well, what did their skin actually look like? Was this an area that had a lot of sun damage, etc., etc.? I don't think there's any other way we could get the level of accuracy that we're looking at. But anyway, this slide focuses beyond. There's another slide like this for how many centimeters to take. This slide focuses on the lymph nodes, because that's what I'm going to base most of my talk on today. What are we doing about lymph nodes in melanoma patients, and how is that changing? And again, as I said, it was in the late 1800s that people realized that melanoma, breast cancer, other cancers traveled through the lymph nodes. Surgeons like Halstead and others started inventing ways to remove the lymph nodes at the time we operated on melanomas and breast cancers, so that we could try to get a cure for those cancers that hadn't spread beyond the lymph nodes. In the late 1980s, my mentor, Don Morton, invented this sentinel node biopsy concept, started working on cats and eventually on people, and by 1992 it had been developed to use a technique where we could find just the lymph nodes that were most connected to the melanoma and remove them and have the pathologist study those lymph nodes very intensively for the earliest signs of metastatic melanoma, finding the spread of the melanoma earlier than we ever could before. And we recognized pretty quickly that the thicker the melanoma, the more likely it was to have already traveled to the lymph nodes. But this is really important to do. The thicker the melanoma, the more likely it is to have spread beyond the lymph nodes. So the question for any individual case is, which one, sort of like the Goldilocks question, which one is not too cold? There's no chance it's either place. Which one is not too hot, that even by the time we find something in the lymph nodes, it's already beyond the lymph nodes? Which one is just right, where only the lymph nodes would be involved? If we remove them today, we stop the process and never go forward. Anyway, in general, in the old days, about 1 millimeter was considered the cutoff. Below a millimeter, don't need to check the lymph nodes unless there's some specific problem with the melanoma, some specific high-risk feature. Dr. Chen talked about some of them. The middle, this 1 to 4 millimeters, was kind of considered the sweet spot. Beyond 4 millimeters was too deep. Below 1 millimeter wasn't deep enough. But in a millimeter, in 1 to 4 millimeters, you could just find it in the lymph nodes and go from there. But still, if you found it in the lymph nodes, the surgeon should take all those lymph nodes out. Just 6 years ago, I think this scheme was very, very widely recognized. Now, how has it changed for the sentinel lymph node biopsy? One thing is we've kind of changed the numbering. We've changed the bottom number. And second is we've recognized there isn't truly just one sweet spot, that every person is different. So now the number is 0.8, not 1 anymore. We're now rounding it to 1 decimal place when we talk about the thickness, even though some of you might have had your pathology reports in, but mine said I was 0.77. As of January 1st, 2018, the rule was you could measure it to 2 decimal places, but report it, round down to 1. So 0.77 would be 0.8, 0.74 would be 0.7, and so forth. So at 0.8, we're thicker. If the lymph nodes appear normal, they feel normal, they look normal, then we would do a sentinel lymph node biopsy. Even many thicker patients, we found that you can find melanoma in the lymph nodes and nowhere else. And so that's where we use the sentinel lymph node biopsy. And the most important thing in many ways, although we're doing it to find the positive, is what happens if it's negative, okay? I'll always try to stress that even though the lymph node is negative, it's not a guarantee that the melanoma could never come back, okay? It's a very reliable sign, but it's not an absolute that the melanoma could never come back. It could come back in those lymph nodes because there are a few nodal recurrences among those sentinel node negative patients. Currently in our hands, about 2 or 3% of people who are told their node is negative someday come back and have a positive node. Either we got the wrong one, or it was too small to be seen, or whatever it might be. And the last sentence has therapeutic value for the sentinel node positive. Here's where most of the change, the thought has come. So as I said, got a positive node, it was like a reflex. Go back and take out all the lymph nodes because we thought there was value to improving the outcome for people if we took out all the lymph nodes. Now this is where a lot of thought is going into. Now let's put this into the big picture. How did this fit into the whole treatment plan? So whatever stage of melanoma we had, the standard thinking, as I said, honed over more than 100 years, was that the surgeon's job was to get rid of all the cancer. NED, no evidence of disease. That's the pathologist saying you've got it removed. That's the oncologist saying I haven't done any test I can think of, I can't find it. Whatever it might be, that was the surgeon's goal. Remove every trace of everything, including removing all those lymph nodes if the sentinel node was positive. Then send the patient over to Dr. Grossman, Dr. Ehrlich, one of the oncologists, and have them figure something out. Up until recently, obviously we've always here at Moffitt preferred a clinical trial for our patients, but up until recently we had 2 different FDA-approved adjuvant therapies, interferon or ipilimumab. Adjuvant therapy you'll hear about in the next talk after surgery, even though the surgeon says no evidence of disease, the pathologist says everything's out, yet we know high risk for recurrence, so what are we going to do about it? And then if, despite that treatment, the tumor came back, well, start over. Do surgery again if you possibly could. And if you couldn't, then go back to the oncologist for something else. So this has changed so much that, again, people are asking me all around the world what to do now. First of all, the big change from the medical side, the recognition that the new anti-PD-1 antibodies nivolumab, and as of Sunday, pembrolizumab. We got just on Sunday, got the latest data about pembrolizumab that Dr. Grossman will talk about, that made it clear that the anti-PD-1 antibodies after surgery, adjuvant treatment, seem to be better than what we've expected and experienced before with either Ipi or interferon, and certainly less toxic. Yes?
You mentioned here about preferred clinical trial.
Right.
Does that mean experimental or is that just tracking?
A clinical trial isn't necessarily involving experimental drugs, but it could be using standard drugs in a completely new way, or it could be saying, we've been doing this for years, and no one's ever really measured exactly the benefit that we're getting. But in this particular case, what I mean when I said a clinical trial was preferred is I think over the years there was enough uncertainty about whether interferon was really that useful, whether ipilimumab was too toxic, that any oncologist would say it was fair game to compare those in a randomized trial to something that had not been tested yet, or to omit them altogether to use a placebo. You'll hear about studies that involved a placebo in this setting so that either the patient or the doctor knew what was the person getting, and we could really test very scientifically, was it preventing the melanoma from coming back.
Very quickly, if I understand you correctly, even if you had the surgery, the surgeon is fairly confident that everything removed with the bowel is you're suggesting that a clinical trial still should be?
Absolutely, in the right setting. So it's something I hear over and over again from patients. The doctor said he got it all. Well, he may have said that, or he may not have. But what he meant, or she, if it was a female surgeon, is that the pathologist told me that all my margins were negative and I didn't leave anything detectable behind. That doesn't mean the cancer is cured. We've known for years and years that somebody could have a completely successful surgery and then years later the melanoma pops up again. Same place, different places. How was that? I thought you got it all. Well, I got everything we set out to do. We did everything we set out to do, removed the area, got a negative margin. But if there are other cells 1 millimeter beyond where the knife was, or a foot away in some other part of the body, the melanoma would recur if we didn't do something.
From new thinking, because mine was excised 2.5 years ago. That wasn't offered to me. Should I now consider?
No, definitely not. But we'll come back to that again. This is based on the risk of reoccurrence. If the risk of reoccurrence is low, we're not going to do any treatment today. If the risk is high, we might want to do treatment, yes.
Where does radiation fall?
So in this paradigm for melanoma, there were times we would do radiation and specific situations. We don't have a radiation lecture today. There's one particular type of melanoma, desmoplastic melanoma, that we find to be more radiosensitive than other forms, so we use it a lot. And there are a few times when, if the surgeon didn't feel like he got it all or felt confident that it was completely removed, that we added radiation on top for an extra layer of security at that site. But in fact, in the big scheme of things, it's actually only a small minority of our patients that get radiation as part of their initial surgery. Yes?
And why is that? Why is radiation one of the last things to use for?
It's a complicated question. And in general, if you look at all different kinds of cancer, melanoma is not one of the more sensitive ones to radiation, meaning that you have to use a much higher dose to kill a melanoma cell than you would have to do to, say, kill a Merkel cell or a squamous cell or a basal cell cancer. And that elevates the risk, changes the risk-benefit ratio. But the other reason is because if the melanoma, remember what I said earlier, if the risk of the melanoma coming back in that one area is high, the risk of it coming back somewhere else is probably even higher. So in general, people have not focused as much on, well, let's use radiation to mop up in the lymph nodes or on the skin, because they were worried about the lungs or the liver or the brain. There was another question. Yes?
If all your margins came back clear and all your lymph nodes came back clear, okay, does it depend on what stage of melanoma you're into as to whether you get treatment or not?
So the question was, if your margins are clear, your lymph nodes are clear, then do you still get adjuvant treatment? And that's what I was coming back to. It depends on the risk. There were a few times with very, very thick, nasty melanomas where even if everything else was negative, that we thought about using interferon. But over the years, pretty much most of these patients that went on a trial or got treatment had positive nodes. The thinking was if it could already spread to the lymph nodes, it could spread somewhere else. And that's where most of this has come. And because everything appropriately, I think, was focused primarily on the chance of distant spread, that's what's caused the change in what we do surgically. Because if we can treat the distant tumors differently, does that change what we do for surgery? And the answer is yes. In fact, one of my friends and colleagues, Merrick Ross, who's in Texas, said, it's the perfect storm. And what is a perfect storm? Everybody know it. It's a common phrase. The perfect storm meteorologically is at least two major storms that actually collide and form one even bigger storm. In 1991, that's what happened when a hurricane and a nor'easter collided over New England and went out to sea. And of course, 13 people died from that perfect storm, including all the people on the sword fishing boat and one of the rescuers who went out to rescue them. But that collision of things is what we're having happen in melanoma today. We've recognized that the treatments we have are better than we thought, that the extent of surgery we were doing wasn't as necessary. We didn't need to do all that surgery to achieve the goal of a high survival rate and good ultimate control of our patient's disease. And it started by asking the question, does everyone need a node dissection after their positive lymph node, or could we just do a ultrasound and keep an eye on the remaining lymph nodes? And we found that we actually could, although there were lots of good reasons to do a lymph node dissection. When we asked the question, does it actually improve the survival to take out all those remaining lymph nodes? This is only if it's just seen on the sentinel node biopsy. The answer was no, that we didn't see a benefit from taking out all the remaining lymph nodes. If the sentinel node was positive, and if the patient was willing to come back and come back frequently for checkups. This is a second trial showing the same thing. So now we've changed that recommendation. Complete node dissection or observation are options, and it's changed this thought process to where we want to achieve the highest survival, but perform the fewest lymph node dissections we can while maintaining control. And here is the bottom line, like Dr. Chen concluded with her bottom line. Couple of key points, and then we'll conclude and answer any other questions. If the lymph nodes are enlarged, then in those patients, positive nodes, palpable, seen on a CAT scan, whatever, that's different than just seeing something under the microscope in a sentinel node. And in those cases, we want a lymph node dissection in virtually every case. We may use drug treatments before or after, but we're going to usually recommend a lymph node dissection in every case. But if it's only in the sentinel node, while doing that further surgery is an option, we think that if we're careful and thoughtful. Just watching the remaining lymph nodes is an appropriate alternative if the patient isn't going to get any more treatment, and is the ideal approach if the patient is going to get more treatment. If the treatments are working that well, let's go right to those treatments. Monitor the lymph nodes, operate on them later if we need to, and only operate on those people where it's absolutely proven necessary. So with that, I'll stop. I think we have time for another question or two, and we'll go from there.
Sorry.
Go ahead.
So how common is it that you just don't find sentinel nodes at all?
How common is it that we don't find a sentinel node? In other words, we recommend the biopsy, but we can't find it. So that's a great question. That happens about 1% of the time. We simply technically can't find a sentinel node. Sometimes it was right under the melanoma and it's stuck to the bottom, and the pathologist finds us for it even though we never saw it. And the majority of those cases, probably 3/4 of that 1%, are in the head and neck region where we can't find a melanoma. All right. So I think we're time to move on to the next one. And